Welcome to week 2. So I just wanted to put together a brief presentation to think a little bit more about clinical reasoning. I had a few different questions from you guys in this last week, basically asking if I might consider expanding a little bit more on what I lectured on week 1. So just thinking about that transition from being a nurse to being a provider. And I think the biggest hallmark phrase for that is clinical reasoning. So the bulk of this mini lecture I want to devote to thinking through how we make a differential diagnosis. So first of all, what is clinical reasoning? There we go. Okay, so it's accurately collecting and interpreting data, being able to prioritize that data, appropriately applying current scientific literature that's applicable to your case, generating a differential diagnosis list, and then integrating different types of knowledge into a complete decision-making process. And many of these steps you're familiar with from working as a nurse, so these concepts are not entirely foreign, but how we work through what sorts of things we are reasoning through, that can be different from the clinician perspective, which kind of goes back to what I talked about last week with deductive versus inductive reasoning. So what is a differential diagnosis? So this is really a list of possible diagnoses which might explain what's going on with your patient. So it's for sure going to include any diagnoses that are really likely based on what their symptoms are, and then it'll for sure also include any diagnoses where if we were to miss it, it would be a really big deal. So a high risk of fatality is what I'm going to put here. Okay, so for instance, if a patient presents with hematuria, probably the most likely cause would be something like a UTI or maybe a kidney stone, but bladder cancer should also be on your differential diagnosis list. So if somebody's coming in with hematuria, all three of those things should really be on your differential. And then the more you tease out what's going on in their physical exam and with their history, the better idea you'll have of what's most likely. And unless it can be rather reasonably ruled out, you would need to consider doing tests for bladder cancer. Unless you were able to easily rule it out simply because it's on the list. So unless it's easy to rule it out, then you would need to check into that because of the danger associated with it. So it will also include diagnoses where the likelihood is low enough to not warrant immediate testing, but has been, but you can't completely rule it out. So so maybe with this woman coming in, she's kind of had burning and stinging for burning and stinging with urination for the last couple days, and she's had 3 UTIs in the last year, and you're thinking, I think we have another UTI here. Well, given the hematuria, maybe you feel like you shouldn't totally take the kidney stone off of her differential, even though it's not very likely given her history. That would be an example of something that would fall under there. So then basically you list it all, starting with what you think is most likely, and then working down to what you think the least likely diagnosis would be. So we refer to the most likely diagnosis as our working diagnosis, so meaning we're working it up, we're doing tests to see if that's what it is, or that's what we're choosing to treat off of based on nothing else on our differential diagnosis would be a big deal if we were to miss it, and since this is our most likely diagnosis, we're going to just treat accordingly. You might hear that referred to as treating presumptively. So in general, your list will probably have about 2 to 4 diagnoses beyond your working diagnosis that are very common just in general based on the symptoms that you have. It could be reasonably one of those. And then any diagnosis that's found to be rapidly fatal if untreated, so our don't miss diagnosis, I think of that as our zebras. So unlikely, but it would be important to figure it out if that is what they had. Kind of like our white flags versus our red flags. Our white flag is our UTI, whereas our red flag would be bladder cancer. And then any diagnoses that are specifically suggested by standout features. So maybe they have an unusual hobby, or maybe they recently got back from Uganda, where probably they'll end up being red herrings, but we need to just throw them on the list just in case. And we don't want to prematurely jump to a conclusion. I think it is nice that you're starting to build up that differential list in your head even before you walk in the room. As soon as you find out what their chief complaint is, you're starting to develop a differential diagnosis. But we don't want to jump to what we think it's going to be and have all our questions that we're asking for history focused around the one thing we're pretty sure it is. We want to be able to start with having a broad list that we're willing to become even broader if need be based on what we're gathering from their history and from our physical exam. And I think it's easy to prematurely jump to conclusions, even just when you're working with well-seasoned clinicians who tend to jump through a lot of steps all at once and can kind of leave you in the dust a little bit. Just developing the practice in your mind of making a list. And I think this is something that in general physicians do better than nurse practitioners, just from my own experience. The way that their training tends to be bent, they tend to have much more thorough differential diagnoses lists. So take the time to develop a list and consider what else could be the cause of the symptoms, even if you're going forward with a working diagnosis with your preceptor, and have them take a look at the list that you're developing too. So we want to keep our list broad, and I'm thinking probably a practical one is something that's maybe 4 to 6 potential diagnoses. So here are the basic steps to making it or generating a differential diagnosis list. So we first need to acquire the data, so our HPI, our general history, looking through their chart, the actual physical exam, and then you need to be able to pull what's most important from all of that. You get so many numbers and so much information, and a lot of it doesn't end up really mattering, right? So being able to pull out those key features, and then from that, creating a problem representation, like a statement that basically summarizes what is going on, and then based on what's going on, adopting some form of a framework to help you reason through, based on what's going on, what the most likely cause of what's going on is. So that's typically from your textbook or from one of your pocket guides or things that you've memorized. That's where our frameworks come from. And then taking that framework, because that framework is broad and it's not specific to your patient, being able to take that framework and work in the key features specific to your individual patient that will help you figure out what the most appropriate differential diagnosis would be from there, and ultimately what your working diagnosis is. So acquiring data, just a reminder about OLDCART, so onset, location, duration, characteristics, aggravating factors, relieving factors, and any treatments they've already been trying. Basically acquiring data, that's our S and our O of our SOAP note, right? It includes labs. You don't need to start your differential diagnosis early, but we do want it to be timely, and I already touched on that a little bit, but anchoring bias is a phrase you'll hear talked about, where basically you put too much weight on information that's acquired early on, and then you don't update your differential once conflicting information shows up later. So you hear that the gal who's had 3 UTIs this year is coming in complaining of blood in her urine, and you automatically think this is a UTI. That can be an anchoring bias. She's coming in and she does have a kidney stone, right? And perhaps your assessment of her when you're acquiring data isn't thorough enough to be able to pick that up because you have a bias too early on. So then we need to be able to identify key features. So we're pulling out burning with urination. We're pulling out that she doesn't have CVA tenderness. So this is identifying key features as both positive as well as negative findings. Okay, so with no CVA tenderness and no fever, you're able to rule out pyelonephritis. That was on your differential list. Now you can go ahead and cross it off. That's pretty unlikely at this point, or at least you can move it down the list of possible differential diagnoses. Now's the time when you want to start throwing in all the right semantic qualifiers. So somebody shows up with, over the last 30 minutes, my chest has hurt whenever I take a deep breath. Now we're translating that in our minds to acute pleuritic chest pain. That'll help us when we're working through our frameworks if we're starting to use the right vocabulary. We've made that translation. Or here I've had to use the bathroom constantly and it stings and pees when I burn. You're thinking, okay, acute urinary frequency with dysuria. So now it's time to create a problem representation. So this should include age and gender, any highly relevant past medical history, primary symptom using the semantic qualifiers, highly relevant diagnostic data using clinical syndromes when possible. So if the whole picture is looking like sepsis, or if the whole picture is looking like liver failure, that you're taking that into account. So here would be an example of creating a problem representation. So a 60-year-old woman with a history of poorly controlled diabetes presents with chronic progressive exertional dyspnea with exam and chest X-ray findings of volume overload and with unremarkable routine labs and EKG. So that would be your problem representation. You've summarized it all, you've taken the key findings, and you've made it into a sentence or two that probably pulls a lot from that HPI piece, so that now you can take this and then start to work it up. So we're going to adopt a framework. We generally we use an anatomic framework, a physiologic framework, or sometimes there's other types. I would say generally you're going to be an anatomic or a physiologic framework. So perhaps this woman with dyspnea, if we use an anatomic framework, we would think, okay, what could be cardiac causes of this? What would be pulmonary causes of this? And think through in your head kind of system by system. That would be an anatomic approach. Versus physiologic would be, okay, hypoxic causes, hypercapnia causes, acidemia causes. I generally think it's somewhat easier to go through an anatomic framework, but depending on what the chief complaint is, switching back and forth between an anatomic and physiologic framework can make more sense. And this is also where charts and graphs and algorithms can come into play. So maybe there's an algorithm for working up nausea and pregnancy, or that kind of thing. So you're pulling from your textbooks and your cheat sheets and all of that at this point. So let's say for this woman you've decided that you think it's a type of anemia. There would be frameworks for that. So there's different ways you could divide out causes for anemia, but one would be, is it hypoproliferative versus hyperproliferative? You can see there's different causes for each one. So doesn't necessarily matter so much what your framework is, just so much as that you're pulling from frameworks to help you have a way to think about what this person's problem is. And different types of frameworks might apply. So different ways to think backwards. Okay, so then we're going to basically slot in this patient for this patient situation, I should say, alongside these frameworks that we've made. And then this is where we're ultimately generating our differential diagnosis. So let's say that the problem representation is that a 55-year-old woman with a history of alcoholism and depression presents with chronic progressive bilateral lower extremity edema with an exam notable for generalized edema and a serum albumin of 1.5 grams. So let's say we take an anatomic approach or an anatomic framework to thinking about what could be the cause for her edema. So we look here, and I've created my physiologic framework for what it could be. So I'm thinking, okay, well maybe this is impaired intake of protein, so that could be malnutrition. Or maybe it's an impaired utilization and synthesis of protein. Maybe that's related to liver disease. So these are all different, I guess I took a physiologic framework, not an anatomic one. Sorry for the confusion there. Or what could be another reason? Maybe if it's renally related, so excessive glomerular filtration of protein. I guess I'm kind of going by system too. This is almost an anatomic framework. Okay, or excessive GI loss of protein. That could be related to protein losing enteropathy. So I have my framework, and now I need to be able to individualize it to my patient. So key features, my patient has a history of depression. Okay, well, could that be the cause in that her malnutrition is so bad that she's not taking in enough protein? Okay, so potential there. How about the fact that I noticed splenomegaly on exam along with angiomatas? Okay, well, this can lead to a higher probability of liver disease. So I've said, you can see here I'm going across. For this one, this kind of fits her individual situation. So then this is maybe my highest on my differential right now, with this one coming up next. Okay, what about a nephrotic syndrome issue? So she's got, oops, I switched these. Well, I don't have one. Oh, these two should be switched, sorry. So I did a UA and there was no proteinuria, so we can basically put that at the bottom or just cross it off our list. That's not important anymore. And then over here I see that excessive GI loss of protein. She's not having any GI symptoms. I would expect a lot of diarrhea or something along those lines with that. So this is unlikely too, so I'll just basically cross this off. Now what I like about this model in general is first, it's about just really doing a thorough history taking and a thorough exam, and you don't have to know what the diagnosis is while you're doing that. You can take a really thorough history without having any idea what could possibly be the cause, and then you say, I'm going to let you get dressed and I'm going to step out while you're getting dressed, and then you get online, you pick up all of your reference books that you brought with you, and then you can look up all these other pieces to help you officially form your differential diagnosis and whatever your working diagnosis is going to be from there. And maybe within that research you find out, you know what, I really should have asked about this too, or oh, you know, I didn't think I should bother to check for splenomegaly, but I think I should check for splenomegaly with this patient. So if you need to, you go back in to do the final wrap up with her, and you can say, I just want to check one more thing, or I had just one more question for you, and then work with it from there. I think that's not as intimidating, especially when you're still feeling fresh, like I don't have all the information I would need to do this. And actually, there's two chances for you to do that, because if you go in and you do all your history taking with her clothed, then you can slip out to let her get dressed for her exam, or undressed for her exam, and you can do a little bit of research then too. So you can slip out and take advantage of slipping out before she gets dressed, as well as, before she gets undressed, as well as when she goes to get dressed again. So that can be ways while you're still novice to be able to, and I still do this, so I'm giving you the tricks of the trade that I still utilize. Gives you a chance to feel like you can get your feet under you. And knowing her chief complaint before you even go in the room. Sometimes I will walk in with somebody 15 minutes late. Why? Because I was just researching on UpToDate before I walked in, because I didn't feel like I knew enough about alopecia to be able to develop much of a differential. So that's fine. Give yourself some grace there. As long as you need to do it, you do it. So I just wanted to work one case through from start to finish now that we roughly know those 5 steps. So this was me a couple weeks ago. Well, more like a week and still recovering. So steps 1 and 2 are acquire data and identify key features. So for me, I had a really bad sore throat. So my history, this is just kind of loosely put on here, but besides having a sore throat, I had a cough, congestion, malaise, myalgias, pretty bad headache, and hoarseness. which is why I had such a low voice for my lectures last week. So when you went through Old Cart with me, I said my pharyngitis has been about 2 days. Though I'd been feeling under the weather for about 6 days. That would include my congestion, malaise, myalgias, the headache, and whatnot. But the sore throat was my primary concern. So for the location, I said primarily my throat, but again I have a headache and I have the mild sinus tenderness as well. Duration, my sore throat's basically constant. I describe it as sharp. It particularly hurts to swallow. Maybe I give it a 4 out of 10. And then for aggravating factors, I would say being outside in the cold makes it worse, makes me cough more. Swallowing and coughing make my throat hurt more. And then for relieving factors, I'd say warm liquids on my throat, hot showers. And then for treatments, I've been doing saltwater gargles, Sudafed, cough drops, cough syrup, and a lot of aromatherapies. And then on physical exam, you noticed I never had anybody give me a physical exam, so I'll just make this part up. So we'll say that my nasal concha and my pharynx were both erythematous, and my nasal mucus was clear to yellow. No white exudate was visible on my posterior pharynx. And then I had anterior cervical lymphadenopathy. My lungs are clear. And then I have normal vitals and I don't have a fever. And you would probably ask me a lot more questions than just that, but just as a rough overview, that's what we're going to go with. So let's think about what my sentence that kind of summarizes it all is. Say, 27-year-old female with a history of postnasal drip and a tonsillectomy and adenoidectomy presents with acute pharyngitis, rhinitis, and cough. Physical exam is notable for pharyngeal erythema without exudate. Okay. So steps 4 and 5. We want to adopt some form of a framework and then apply key features to that. So I've kind of put our framework up here. For our framework essentially is just thinking of what are the typical causes for pharyngitis. So most often it's infectious. And now this is where we need our textbooks and where we need our reference guides until we've got it memorized and until we have the experience and the knowledge to back up where we can just work from a framework without having to reference it, right? So causes of pharyngitis, most commonly it's infectious. And from there, we know that the vast majority are viral rather than bacterial, and it's only about 20% that probably need antibiotics. So we kind of go in knowing that. But the big one we need to be able to catch would be strep. And so with strep, we know that typically there's no cough and there's no runny nose, and you would see tonsillar exudates. So I maybe go into the room kind of having all of these loosely on my differential, right? Go into the room to see myself. But really, we can basically cross strep off of our list because I have a cough and there were no tonsillar exudates. So we cross that off, and that also means we don't need to culture it. And then we want to make sure it's not mono, right? Common ages for mono would be 15 to 30. They typically would have a fever. I didn't have a fever. They also would have a sore throat and malaise, which I did have. You'd also expect to see exudate. Again, I didn't have any exudate. And then you see that, oh, with mono, oftentimes there's hepatosplenomegaly. Oh, well, I didn't even think to check that, so that would be something you could go in and check when you come back in the room. Also, typically the posterior cervical lymph chain is enlarged, and for me it was the anterior lymph chain. So not likely going to be mono, though you could certainly do a CBC or check further in on mono if you wanted to. Gonorrhea, my history wouldn't make that likely. based on lifestyle factors, and then also I would expect a fever with that and dysuria with that, and typically some kind of a greenish exudate, which I didn't have. Diphtheria is pretty uncommon, so that would be factored in, and then typically you would see like an adherent gray membrane across the pharynx, and I didn't have that. So you're kind of just going through and thinking, okay, what of this is consistent with our symptoms and what isn't? And for everything on the right side, those are my non-infectious possibilities. And probably the biggest thing to make those less likely to be our working diagnosis is just the fact that it had an acute onset, and it was accompanied by all those other symptoms that are more consistent with it being an infection, right? So yes, I have postnasal drip, but it's not likely. And I do have a persistent cough, but the fact that it was such a fast onset and the severity of the soreness doesn't sound like it's probably related to that. I don't have a history of allergies. I'm not a smoker. I didn't come in with a story about how I just swallowed a Lego, right? So all of those things make the right side less likely to be a cause. And I didn't have any symptoms related to GERD. So what you could then put for your official diagnosis, you've thought through all your differential diagnoses, and maybe strep is still sort of lingering, or mono is still sort of lingering, with you thinking, it could be, maybe if she calls me back in 2 days and says, now I've got a fever, maybe that's going to change, right? But for now, probably our working diagnosis is that it's viral. So as far as what you would put for your official diagnosis in your SOAP note under A, I'd probably put upper respiratory infection. You could also put pharyngitis. That would be appropriate too. I generally think as specific as you're able to be, the better. As far as billing goes, there's a code for acute pharyngitis. There's a code for viral upper respiratory infection. So kind of whatever you wanted to do there. If you were going to have a treatment plan in place for both pharyngitis as well as upper respiratory infection, and those things were kind of different, then that would be fine to just list them both. And then when you're putting out what's in your plan for what you're going to do for one versus the other, if a different plan is in place for rhinitis versus pharyngitis, then you could list them both separately. So for me, or actually when I first presented, I probably could have just as easily been laryngitis. Any of those honestly would end up being an appropriate diagnosis, and whichever one most fully incorporates all the symptoms. I think putting pharyngitis as your diagnosis is maybe, while it would be fine for billing and you can move on just fine, it doesn't speak to whether it's related to GERD versus whether it's related to a virus. So I think my working diagnosis would be, as I'm making it up as I go here, I'd say it's a viral upper respiratory infection. And then all my plan would fit under that easily. So that's how I would get to a diagnosis. Hopefully that's helpful. Sorry, I keep coughing, guys. Okay, and then the other topic I just wanted to touch on to wrap up here is, what is your scope of practice? So as a CNM, you graduate, you take boards, and basically that'll get you your certificate. That makes you a certified nurse midwife. That certification piece comes from AMCB. They're the ones that issue the board exam. So AMCB says you're certified and says this is your scope as a CNM. And then from there, based on what state you live in, that scope might be somewhat licensed. So while that's your full scope, federal or state laws, or even your practice environment may limit a portion of your scope. So let me give some examples. Medical marijuana is legal to prescribe in some states, but not in others. So that's where federal or state laws can come into play. In Minnesota, I don't have to have a physician review any of my charts, whereas if I lived in Tennessee, a physician would need to sign off on 20% of my charts where I wrote a prescription. In my current practice, I continue to provide newborn care up to 2 weeks, whereas my certification scope as a CNM, that would go up to 30 days, but it's limited to 2 weeks in my current practice. However, if I was in a hospital practice, I would likely cease newborn care following clamping of the cord. I would just be done at that point, maybe with the exception of breastfeeding support. You might be supporting both baby and mom. Maybe in some settings, like if mom came in and had nipple yeast, you would go ahead and prescribe something for the baby as well. So you'd be treating the baby's oral yeast infection as well as mom's nipple yeast. So it's our responsibility to stay fresh on the most current guidelines and laws that govern our scope of practice. So this is the definition of the scope of practice that ACNM gives. So midwifery is practiced by certified nurse midwives, and certified midwives encompasses a full range of primary healthcare services for women from adolescence beyond menopause. These services include primary care, gynecologic and family planning services, preconception care, care during pregnancy, childbirth, and the postpartum period, care of the normal newborn during the first 28 days of life. Oops, I just said 30. It's 28. And then treatment of male partners for sexually transmitted infections. So that is, in a nutshell, that is your scope. I went ahead and added in week 1, I put in additional resources that gave you links to the full breakdown of what I just read, that basically your whole education experience at Bethel is shaped after. That's what helps us be certified, is that we're meeting each of the criteria there for enabling your scope. So your expanded scope is available to look at there if you look under week 1's resources again. And then I also put links for Minnesota state laws that are related to APRNs. So yep, okay. So it's up to you /laws/community resources for how much you decide you want to use for your scope. So I know plenty of midwives who don't like to bother treating male partners for STIs, and I know other ones who do. So that's up to you and your community and your laws, etc. So it could also look really different based on your practice setting, like I said too. So basically what it comes down to is, are you reasonably in line with current guidelines? After you think about ensuring that you're well within the umbrella of state laws and of your CNM scope, you know, whether you choose to prescribe one medication or another medication, that's where the are you reasonably in line with current guidelines works. So are there specific practice guidelines where you work that says, you know, if there's a postpartum hemorrhage, this is what you need to do, versus having it be looser to you can give this dose or you can give that dose, etc. Do you have research to support your management recommendations? For instance, if a woman comes in with bacterial vaginosis, we know that the CDC says, hey, you should use Flagyl. Okay, let's say you decide you're not going to use Flagyl. Let's say you decide you're going to use boric acid. Is there research to support your choosing to use boric acid instead? Is there research to support your backing up a low sugar diet and other pieces of education that you decide to go along with it? So, I mean, honestly, guidelines are always changing, and new research is always coming out, and the way you practice probably isn't going to look identical. I'm sure it isn't to everyone else that's in your practice group. One person's recommending a castor oil concoction for induction, whereas somebody else is recommending sex, versus someone else is saying acupuncture, versus somebody else is saying do all of them. You know, so there's going to be differences there, but our responsibility is to know what research says and to fully educate our patients based on what that is as well. Something else to think about within that realm of is it reasonably in line with current guidelines? Is it approved for the use that you're using it by the FDA? And if it isn't, is it widely used for how you're choosing to use it? A good example of that is Cytotec. Cytotec is not approved by the FDA for cervical ripening, but it is widely used that way. So the chances of you getting in trouble for using it for cervical ripening are going to be pretty slim, given that that the common understanding among your colleagues is that that's an appropriate use for it. Okay, I think that's probably pretty good there. So what degree do your peers practice similarly? I think about with legal allegations, it may very well be your peers on the stand and not necessarily somebody you're directly working with. But say I was in a case where a baby ended up dying, and all of the strips that were tracking baby's heart rate are essentially on the stand too. They might bring up another CNM from another state to say, okay, based on the decels you were seeing here, was it reasonable that she continued to anticipate a spontaneous vaginal delivery, or should she have gone to section? So to what degree are we practicing in a way that's consistent with our peers? Ultimately, though, there tends to be more than one approach to most issues. So you do your best with the resources that you have, and you stay dedicated to evidence-based practice. And one of the three pieces that makes up evidence-based practice is that we're incorporating patient values as well. So it's not just you that's making these decisions, it's the women that you're working with too, and wanting to make sure that we're giving them a full voice and full education to give them that voice. There's no perfect way to do medicine, but there is a process to help guide us. So you may determine to manage one way, and I might determine to manage a different way. But let's just continue to spar with each other and all continue to grow with each other to become better practitioners. I think learning to educate one another is one of the trickiest but most rewarding pieces in practice. And in general, we do want to err on the side of caution. You only have one license and you should protect it. So anyway, I hope that that's helpful to just kind of give you a larger framework for what you're stepping into. And I hope you all are just loving clinicals. I think if you're feeling overwhelmed and very nervous, know that you're absolutely not alone. So I hope that that kind of gives you freedom to spread your wings a little bit and mess up, and that's okay. Anyway, feel free to email me if you have any questions, and I look forward to continuing this journey with you guys. Have a great week.